It's working. All right, we stopped either at anterior tibia. We talked about that. Perineal tendonitis, gastrocnemius. What is your gastrocnemius? What is the gastroc? The gastrocnemius. So you don't know that word. Think about the places that we're talking about and the chapter. What's the chapter name? It is your calf. Okay? The big muscle in your calf. There's a smaller muscle underneath it, your soleus. All right? But the gastroc can get a strain. Variable amount of pain, swelling, and disability may complain as if being hit in the calf with a stick, point tenderness, and there is functional strength loss. How are you going to find functional strength loss? Pick your foot up is the opposite side. But toe raises. If you're doing toe raises, right, they're even. So now you're splitting the work. So one-legged toe raises. Now let's try the other. Can you do it the same? So there's your functional strength loss. Rice, non-steroidal anti-inflammatory drugs. What would be an example of an NSAID? Ibuprofen is perfect. Yes. How about another one? Tylenol is not. Which is ibuprofen. Yes. There's another one out there. Aleve. Very good. All right. Put a heel lift. What is that going to do? Put a heel lift in your shoe. All right. So if this doesn't, all right, this is true. Back in the day, when I was your age, my Spanish teacher wore these shoes, wore heels every day. All right. So she was having a problem because for 6 to 10 hours a day, she was wearing heels. So her gastrocs were actually having contracture. So she would get out of her heels and then she would feel it on her calf muscle. All right? Because the heel is not down on the ground where it should be, it's up higher than the balls of your feet. So it allows the gastrocs to not have to be stretched. That's the same thing we're doing here, so we're not stretching the strained muscle. Now, if I put a heel lift in one shoe, yes, you must. Why? Yes, to make it even. What happens if you don't? You are lopsided, and then your hip starts to hurt because now your hip is not level. Okay? Even the smallest amount, you need to make sure that you go ahead and put it in the other one. All right? Elastic wrapping and a gradual range of motion exercises. Here's all your fun stuff. Medial tibial stress syndrome. It's referred to as shin splints, and that's a catch-all term because you can get them in about 3 different places. All right? But everybody says, oh, I got shin splints. Why? Because it's their shin area that hurts. So, commonly caused by repetitive microtrauma. We see this in something else. What else was that? Tendonitis? Commonly caused by repetitive microtrauma and most commonly seen in basketball, running, and gymnastics. We see it also in soccer because they are. We can see it in football because they are running. We can see it in track. So you just can't say, okay, it's just basketball. All right? What do you think has probably the poorest sole on their shoe? What sport? Soccer or football? Because it's got to be hard enough to hold the cleat in place. And so you have to give up something else, which is going to be absorption. Includes weakness of the leg muscles, shoes that provide little support, and training errors such as training on hard surfaces, and then, of course, overtraining. So we see this every year, every fall. Here they come. They are going to play football. And every year, every fall, we start seeing the folks come in and say, I've got shin splints. We look at them. Yeah, you got shin splints. Did you do anything over the summer while you were sitting at home? Nope. You did no preconditioning? Nope. Heavens. So that's going to do it because now their legs are saying, I'm getting overtrained because I'm working out for 3.5, 4 hours a day. So what is shin splints? What do? They involve one of two syndromes, a tibial stress fracture or an overuse syndrome that can progress to an irreversible external compartment syndrome. Okay. How's that jibber jabber, right? Okay. So we've got his leg here. Okay. You feel on the top, that's the spine of the tibia because it comes to a point. But usually you feel it down over here. All right. So the tibia is a great place for muscle attachment. All right. The external compartment is on the outside, and this starts getting tight. Remember that we talked about the anterior compartment syndrome? Okay. And it is wrapped in fascia. So if it gets all swollen, it has no place to go. So normally, you'll feel them right here. Sometimes if you feel them on the top, you probably need to go ahead and go and get you a bone scan or get your x-ray and seriously worry about whether or not you have stress fractures. So, oh, it looks like I pushed a button a couple of times, huh? All right, there's 4 grades to the injury. 1, pain occurs after athletic activity. And since it occurs after activity, they usually blow it off and just go home, unfortunately. Then it's before and after activity, not affecting your performance. Then what happens as they get worse, before, during, and after, and it starts to affect their performance. Usually that's when we finally get to see them. But see, we're already getting down into phase 3. 4, the pain is so bad or so severe that the performance is impossible. We don't want to get to 4, ever. All right? So we can have them step on a piece of paper, and before they do that, we take some betadine and we put it on the bottom of their foot. See, do they got a flat foot? Do we need to build an arch? We look at their shoes. All right. We also look at the callus patterns on their heels. Do they got a good strike? Heel, outside heel should come across to the inside toe. Do they have a good heel strike pattern? If they don't, we can try and manipulate those with orthotics. Refer a physician referral to rule out a stress fracture by a bone scan and x-ray. Remember we saw that picture where the bone scan was hot spot across there, but it wasn't broken, but it was hot. Activity modification. I'm sorry, coach, but he is not to do wind sprints. He is not to do anything that is hurting his leg. If you need to do conditioning, they can come and do conditioning on the bike. And your rule of thumb would probably be they need to ride the bike twice as long as what they would be running. So they go, oh, I don't want to do that. Correction of pronation during walking and running with custom orthotics. All right. We haven't talked about that, have we? No, because we're too far down. Pronate and supinate. Okay, you've had medical terminology. You should know that. Supinate is to turn this way. Pronate is to turn this way. So if I'm pronating, I'm walking on the inside. I don't have a good heel strike. I think I stopped you one time and took a video of you walking, didn't I? Because I wanted to see if you were pronating. Those people don't know they're doing it. The greatest way to show them is Pull your camera, put it on video, have them walk on the track, and you'll see their feet are this way instead of flat. They're pointing towards the outside like this. The other thing you'll see is you'll see the heel strike if they've got shoes old enough to where they've actually had time to wear down the rubber on the outside. If that doesn't work, take the shoes off and look inside and see where the foam is getting pushed down. All right? So if they're like this, there's that old song, foot bone connected to the leg bone. That makes sense. If I'm screwing up down here at the feet level, it's going to screw up above it and mess up that, which then goes to knees, which then goes to hips. So go and see about custom orthotics. Now, who's going to do that? You have to. You go to the orthopedist. The physical therapist can help you get orthotics. If you need to, you see the podiatrist. The podiatrist will make the orthotics. But it's somebody that's called an orthotist, okay? That will help you make those. Don't blow off shin splints. Don't say, come on, Joey, get over it. Horror story, and I'm sure I've told you this before. Volleyball girl up at Henderson. Yeah, they ran 5 miles for volleyball. Okay, so they're doing an aerobic activity for an anaerobic sport. I don't know that there's very many volleys that last an entire minute. Most of them are 15, 20 seconds. 5, 6 hits across the net, somebody's going to screw up and score. Especially if you got somebody good. So they would run 5 miles. I told the coach and said, Coach, this kid is done. They're doing the bike. Well, I never saw the kid come in and do the bike. Next thing I know, the kid shows up at a football game to see the doctor. The doctor says, you're not even walking out of this training room. They took a wheelchair. We borrowed our wheelchair up there, put her in it, and said, you are in there for 6 to 8 weeks. Do not get up. Do not walk on your legs. She had stress fractures so bad that that's the only course that they had as far as making her better. So, don't blow them off. Anterior tibial compartment syndrome, we've touched on this all this last 2 days. Serious condition has serious consequences, trauma to the anterior lateral aspect of the lower leg. So, anterior tells you it's where? It's in the front. Lateral tells you where? To the outside. All right there. So if you'll pull your foot up, can you pull your foot up? Can you see how that tightens up? That's the muscle right there that's doing it. Okay? So you bruise this muscle, or even more severely than just bruise, you really bruise it, and it's going to swell. But the swelling's not going to have the entire area of that lower leg to go to, and it's caught by the fascia. You have nerve supply, and you have blood supply going through there, and it will shut those off. Well, if you shut off nerve and blood supply, this part doesn't get fed blood, oxygen, nutrients, and so it dies. Okay? So it's really important, just like we saw Coach. They take it and they lance it open and they leave it. They put some gauze over it or some an antibiotic fighting type deal over the top of it, and voila, you're there until the swelling starts to go down and they can stitch you up. You're going to end up with a huge scar. So from then on out, you're probably wearing pantsuits if you're a girl. All right? Positive signs include tightness to the skin and tightness to the skin of the anterior lateral aspect of the lower leg. Drop foot. What's drop foot? When you can't pick up your foot. Exactly. They also get numbness of the lower leg, cold foot, loss of feeling to the foot or the lower leg. Do not go get an ice bag, put it on there, and wrap it with an ace wrap. Because now you're just increasing the pressure. All right? So don't do that. Go straight to the ER. Don't say, well, it'll be better tomorrow. By tomorrow, this skin on his foot will be peeling off because it's dead. I mean, literally peeling off. All right? So your athlete may lose his lower leg if treatment is denied or delayed. All right. So rehab for all this stuff. VAPS board. VAPS board, we got one. Matter of fact, I think we got two because we got one up in the other room. All right. Those little balls, they screw to the bottom for a larger range of motion. You've seen them do tubing for inversion, eversion, dorsal, and plantar flexion every time that we see folks that get a lower leg injury, right? So, stretching, strengthening, toe raises, functional progression. We know what functional progression is? Well, I mean, functional means the things that you do in life or in sport. And so, first one is just a walk. So we'll have them walk. Next one would be jog. Next one, everything in a straight line. Then we go from there and start getting them to where they're now doing sport-specific deals. So we go baby steps from walking all the way to catching passes, making layups. All right, and then tape it for prevention of a re-injury. Now, if you've got an ankle sprain, right? How long is it going to take for that soft tissue to heal? Like a week? No, no. 2 to 3 months. All right. So does that mean that this person's out for 2 to 3 months? Obviously not. All right. So we can use the taping to help limit him getting in positions to where he re-injures this or injures it more. But as long as he's pain-free and functional, he or she could go back out and participate again. All right. That sounds great. That is pretty much over. And then this lovely thing is going to be what your goal is to pass these questions. All right? So that way you can see how many questions? A bunch. Just one. Overall, I don't know. All right? You certainly will need to know your compartments. Should have had them. Compartments, we're going to review everything tomorrow, but make sure that you start studying what compartment has what in it. As in, which compartment contains the muscle that dorsiflexes the ankle and extends the toes, and also contains the anterior tibial nerve and the tibial artery? Going to be the anterior compartment, lateral compartment, deep posterior compartment, or the superficial posterior compartment. All right, so know what compartment has what in it. All right, your listing questions. What are 4 major ligaments of the ankle? Y'all know that? Probably ought to know that, right? All right, what are 4 of the 6 rehab techniques or treatments for 1, 2, 3? There's actually 7, but if you name, you're going to need to name 4 of those. All right, some multiple guess, 7 of those. Looks like 11 true and false. And then you actually are going to have to know your symptoms of ankle sprains. 1, 2, and 3. What are the symptoms? I told you yesterday, the day before, the key words you have to look for. Okay? The other thing would then be, what are the treatments for ankle sprain, grade 1, grade 2, and grade 3? All right? So, when we get done with this chapter, who has not who has not done